Hi, it's Mo Bhandari, Editor-in-Chief of Ortho Evidence, and I'm here on an orthopod with Dr. Jason Busse. Now, Jason Busse is the Director of the National Pain Center at McMaster University, and recently, very recently, about the last week or so, has published in the Annals of Internal Medicine two fairly high-impact papers that have a considerable amount of practical importance to the practice of orthopedic surgery as it relates to pain management. Welcome, Jason.
Thanks for having me.
I wonder if you might just summarize principally what your findings are. And I know I'm going to get you to summarize a couple of the papers, but I wonder broadly, your whole issue has been what works for pain management in musculoskeletal pain. And I guess you also speak a little bit about the challenges of opioid use and predictors of those individuals who are more likely to use it more often than not. And I wonder if you could speak to those issues for us.
Yeah, absolutely. So a few years back, we were approached by the American College of Physicians. They were putting together a new clinical practice guideline. They had put out guidance in 2017 about management of low back pain, and they were getting requests from their members to put out guidance around management of other musculoskeletal complaints. We began talking with them about what kind of evidence would be helpful for their guideline. And in the past, what they had done is do sort of narrative syntheses of the evidence. And we were aware that there were a large number of therapies available to treat all of these non-low back acute musculoskeletal injuries. And so we suggested to them doing a network meta-analysis, which I know you're familiar with, but for anyone that hasn't come across this yet, it allows you to look at the comparative effectiveness of different active interventions, even if they haven't been compared directly in head-to-head trials, by the fact that they have a common comparator. So in this case, almost everything is compared to placebo. So they were interested in that, and so we undertook to do a large network meta-analysis looking at every therapy for all kinds of non-low back acute musculoskeletal pain complaints. And we found 45 therapies that we evaluated. And what we found was that the most promising treatment in terms of risk benefit was topical NSAIDs. Now, topical NSAIDs, non-steroidal anti-inflammatory drugs, have been a mainstay in Europe for quite some time, but they were only approved by the FDA in 2007. They do have some presence in North America, but they're not widely used as far as we know. Oral NSAIDs are. But what we found when we looked at the harms and benefits, as you would understand, as it would make sense, when you take in enough NSAID through tablet form to get to a sore ankle or elbow, wherever you want to get the action to occur, you have to digest it and you run into some risk of gastrointestinal adverse events. You don't get that with a topical. You apply it directly to the site. It has a local mechanism of action. So we found the topical NSAIDs were the best performers. Oral NSAIDs were next, but you do have to accept some risk of adverse GI events. We found acetaminophen, with or without diclofenac, was the next best option. And those were the top four supported by at least moderate certainty evidence. When you get below that, there were some non-pharmacologic therapies that appeared potentially promising, but only supported by low certainty evidence. So that means we need more evidence in order to understand their role. These were things like TENS, for example. Looks potentially promising, not enough evidence to be conclusive. And what was really surprising to us is no opioid demonstrated greater benefit than NSAIDs, but they demonstrated the greatest risk of harms. And so we ended up, out of all 45 therapies, saying opioids seem to be one of the worst options, which is interesting in the sense if you look at large studies of how American physicians are treating ankle sprains in the US, these are type 2 ankle sprains. About 25% of patients will leave that encounter with a prescription for opioids. So the associated guideline that the ACP put out said, for these types of injuries, look to a topical NSAID, if not feasible, an oral NSAID or acetaminophen, and stay away from opioids. The risk-benefit return is just not good. It's not a good option. And acute pain by its very nature is going to resolve in about 4 weeks no matter what you do. So there's reason to sort of get into the opioid prescribing at all in these cases.
How difficult do you think it's going to be? I mean, like, you know, when the thing that strikes me is there are 45 therapies that were reviewed, and really you have one that, you know, most would consider, you know, it wouldn't have been high on the list of many of the practicing surgeons just saying this would be my treatment of choice for, you know, even post-surgical pain or post, you know, or, and maybe you didn't specifically address post-surgical pain, but that being said, it seems to me, you know, opioids are still used a lot, a ton actually. And orthopedic surgeons, as you know, are one of the top prescribers, at least in North America, but I suspect worldwide in many cases. Your work here would suggest, Jason, that, you know, it's just one more reason that we should be more skeptical and cautious about opioid use. What do you think, though, is the aftermath of this? So if so, it's put in a guideline. You have a high impact paper. It goes into a guideline. Guidelines support it. What are the steps that you have to take to get the message out around opioids, given the fact that that messaging has been very, very strong, at least in the last, you know, 2, 3, 4 years, at least from my recollection?
Yeah, I think there is a high awareness out there, to your point, that opioids are an issue. You know, North America in general, but, you know, US is sort of the leading prescriber in the world, Canada too. You know, and so we have now looked at you know, one area where there is a lot of prescribing going on with these acute pain complaints. And my hope would be that you know, since it's coming out with the stamp of the ACP, it's coming out their association journal, this is going out to all their members, is that there will be an impact, and that, you know, clinicians and prescribers will have confidence that they're not denying their patients valuable care by looking to an NSAID or acetaminophen instead of an opioid. That it's going to give them comfort that they're not sacrificing effectiveness. And so if that message comes across, I think you're going to see some shifts in practice, but, you know, well, there'll have to be observational studies to see if that occurs. But I do think, to your point, there is a lot of pressure right now to look at non-opioid management of pain. And my hope is that our work in the associated guideline is going to provide some confidence.
Oh, absolutely. And now, can you speak to the generalizability of your meta-analysis or network meta-analysis findings to that specific issue of post-surgical pain? Were there any studies at all included, or how would you know, surgeons be able to use this information? Now, I understand clearly that topical NSAIDs, let's say for someone with chronic pain, you see patients with knee arthritis, they come in with considerable pain. You know, it seems very logical and very appropriate to use the guidelines in that context. But post-surgery, I guess I'm wondering, you know, would this change practice, or how could it change practice?
Yeah, it's another critically important area. We did include some trials that patients presenting with fractures that did not surgical management.
Okay.
So there were some orthopedic population considered, but we did not specifically consider post-surgical pain.
Right. Okay.
Area that we're quite interested in. It's an area that we are looking at. So we've previously, you know, looked at management of chronic pain. Now we've looked at management of acute musculoskeletal pain. I think you're right on. Post-surgical pain is another critical area. There's a huge variability in practice out there. I think there's some areas that are very reliant on opioids, other practices, in particular those in Europe, that have largely moved away from them. And so when you see these huge variations in practice, what it tells you is that they can't all be right. Someone has.
Oh yeah, for sure. And, you know, I mean, and we're seeing, like, you know, just in surveys, and I know you're well aware of this topic area, is that 4 or 5 patients who come in with fractures or to fracture clinics, at least locally at McMaster University and the Hamilton clinics, are taking, you know, self-prescribed to some degree, for the most part, cannabis or some form of cannabis as well, as, you know, as a way to, you know, and the argument there is that it's opioid sparing, and the argument there is that, you know, it provides additional anxiety relief or ability to sleep. But you see, and I'm not trying to deviate us into cannabis here, but the reality is there's a lot of information in that one group of patients. But even with fractures, let's say, Jason, it would still, non-operatively treated fractures, this evidence would apply to that group.
Yes.
Okay. Okay.
we did have some representation of those groups. So we had most of the trials enrolled mixed population. So they included patients with various types of strains or sprains. Some were more focused on specific types of injuries, and there were a few trials that looked very specifically at non-surgically managed fractures. But what you see in this area of research is, by and large, the process of healing and the prognosis is fairly similar. And so you have a lot of trialists combining patients, whether they're coming in with an ankle sprain, whether they're coming in with a non-displaced fracture that does not require surgery. The sense is, pain from these types of presentations is likely to have a similar prognosis and respond similarly to different forms of, to a certain degree.
Now, let's say there are still situations where patients are taking opioids, they're in the clinics, they're having, they have a musculoskeletal complaint. What has your research gleaned and to help enlighten practitioners on those factors that are predictive of people at risk of long-term use?
Yeah, I mean, what we're really interested in is what would be the risk of patient-important harms after they are an opioid for acute pain.
Right.
Fortunately, we do not have literature on that. But what we do have is a number of studies, and we found about 13 studies on over 10 million patients looking at who ends up using opioids, prescription opioids, for a year or longer after they were prescribed acute musculoskeletal complaint.
Right.
And what we found was individuals that were older, were at higher risk, individuals who are coming in particular with a past or current history of substance use disorder, individuals who are receiving disability benefits would be another category of patient that's at higher risk. When you look at the sort of general population, about 6% of those individuals report still using opioids chronically at about a year after they were prescribed for an acute complaint. If you look at high-risk populations, so again, individuals receiving workers' comp benefits, Veterans Affairs claimants, populations with high rates of substance use disorder, you get about 27%.
Wow.
27% end up using opioids long-term. So I do think that if a clinician has looked at the pros and cons, they've decided for the patient in front of them that they are going to consider an opioid, I think it does make sense to look at those additional factors. And the one that we found that was the most powerful was a past or current history of substance use disorder.
Yeah.
But we also found some prescribing features that were associated with prolonged use. And so these could be modified directly by the clinician. In particular, providing an initial script for more than 7 days of opioid use. That was associated with coming to this sort of chronic. And I understand, not wanting patients to have to come back in or to book another appointment. I'll give a little more just in case they make it more convenient. But that was associated with a higher risk of chronic use and also prescribing higher doses. So again, for those patients in which clinicians might decide, I really think an opioid is warranted, keeping that script to less than 7 days and prescribing a lower dose of the opioid would seem to be important features to consider.
What's next for you? I mean, we talked a little bit about post-surgical pain, but when you've looked at this and by looking at what you've done, you're clearly an expert in the area. What are the gaps? Like, what's missing that has to get resolved for us to move forward in the management of pain? Yeah,
well, so there's a couple of things that you've sort of alluded to. One is, what is the role of cannabis? And I in this area too, and you're doing work in this area.
Yeah.
And we do have something that's going to come out probably later this year that I hope is going to be valuable in terms of addressing some of the knowledge out there. We are finishing up one of the rapid recommendations on that topic.
Okay.
I think this issue about how can we do a better job of preventing post-surgical pain, persistent post-surgical pain.
Correct. Yeah.
Is critical. And in many ways, surgery is a controlled trauma, especially with an elective procedure, right? Someone's getting something. They're going to have tissues cut. They're going to have nerves severed. And we do know in orthopedic procedures, there's a high rate of persistent pain. If you look at, some of the trials you've done, the flow trial, for example,
Right.
when we looked at your data, we found that it was around 6 out of 10 patients that had a surgical repair of an extremity fracture was still reporting, persistent pain and some impairment at 1 year after that procedure was done.
And I'll just jump in, Jason, and let the membership know that when we're talking about the flow trial, we were talking about was the fluid lavage of open wounds trial. And that was a trial of the more complex open fracture. So yes, it was on the spectrum of fractures, the more severe types. And you might, that in itself may be a predictor of itself of persistent pain, because these are the more high energy, more severe types. But just so the audience understands what we're talking about.
Yeah, no, it's a great point. And when we have looked at other trials, whether the TRUST trial and others,
Yeah.
more of a mix of open and closed fractures.
Correct.
There is an increased risk with those more high energy fractures. But what we found in these fracture populations, these extremity fracture populations, is that patients' perception around their prognosis, their coping after surgery, their somatic preoccupation, these things appear to have a powerful influence on how they end up doing. And in a sense, it makes sense. If I've gone through sort of a terrible traumatic injury, completely unexpected, these people are often young and otherwise healthy. This is a sporting accident, a car accident. All of a sudden they're rushed into surgery. Someone's putting a nail in them. It's overwhelming. You can well imagine. And when you come out, you could see some people saying, I don't know if this limb is going to be strong again. I don't know if I can weight bear. What if I feel discomfort? Is it more vulnerable to re-injury? And if you believe that, and if you continue to favor that limb, if you continue not to use it, you could see getting into a pattern where it doesn't recover the way it should. And because we've seen this now in a number of observational studies that we've done, we were successful with yourself and other members of your team in securing funding from CHR a year ago to do a randomized control trial looking to see, what if we take people after an extremity fracture repair and we randomize half of those individuals receive usual care, half receive online cognitive behavioral therapy, a brief course, 7 modules to see, can we improve people's coping abilities to the extent that we're going to see a reduction in the rate of persistent pain in the long run. So, that was enrolling. We ran into COVID, everything
Right.
a while,
Right.
but we're very enthusiastic that we're going to start that enrollment again soon. And hopefully in a few years, we're going to get a sense as to whether or not orthopedic patients might benefit from this kind of intervention after surgery.
And you can imagine that it might be some of these, again, to your point, non-pharmacological interventions that have a huge impact on post-surgical pharmacology, like in terms of what they use based on, their perceptions about, their situation. And we see it happen a lot, Jason, in the elective procedures. So, if you flip it around, someone who has chronic pain, who's going to have a procedure that they believe is going to almost be curative, like a total hip replacement or a total knee replacement for the most part, right? The majority of them do very well. It's a different mindset because you've had pain and now you're going to have a short period of pain, but it's going to be relief. The opposite happens in trauma, as you've just, articulated, which is you have no pain. Life is great and going well. And then suddenly you have this traumatic event, just the trauma of it on top. And then you've got all this recovery and you're not sure, right? So you can see it's a complete flip of how things work. But you can also see the power of someone's perception. We've never tested it, so I'm really looking forward to this trial and how it hopefully informs where we go forward. So when you think about next steps and in terms of next programs, it looks like you'll be focusing quite clearly on cannabis. You'll be looking at maybe areas of post-surgical pain. You're looking at cognitive behavioral therapy. Is there anything else we've missed that's coming around the future in the work you're doing?
I think more and more we are going to be trying to refine the methods and the presentation of these network meta-analyses.
Okay.
what has been done traditionally, this, as you know, this is a fairly new methodology. It is gaining traction because, it's the idea of being able to look at the comparative effectiveness of different interventions is very appealing. But historically, what's been done is people have done probability ranking. So they'll say, well, we did our network meta-analysis. Treatment A is, 100% chance of being the best, and treatment B is, and so you get this very nice ranking. Unfortunately, it's completely artificial.
Okay.
That ranking strategy, which is it's the surface area under the curve approach, or the Sucre approach, only looks at the point estimate of effect. It doesn't consider
Look at the variability.
Evidence.
Yeah.
It doesn't look at that. So what we did for this network meta-analysis that we published on acute pain, we've used a minimally contextualized approach for ranking the interventions, which considers the benefits, it considers the harms, it considers the certainty of that evidence, and we've put it all together in one figure. So if people are interested, they go to the paper. You do not have to read the whole paper. You do not have to read the 163-page supplement. Just look at figure 1. And if you see dark green, for the benefits, that therapy was superior to the other ones. If you see dark red for the harms, that therapy was much worse than the comparators. And we think it's going to be a really helpful way to take a complex methodology and make it very approachable for both patients and clinicians. We're in the midst of doing some user testing now. Actually, one of your PhD students.
Yeah, I know
Mark,
exactly who it is. Yeah. Right.
He's leading that. He's doing a great job, and he's going to a lot of orthopedic surgeons, a lot of anesthesiologists. Are using the example from our paper to see, have we optimized the presentation? So I think if we can help add to that methodology and make it more approachable, that's going to be another important area of focus for us.
So let me ask you this, just to that one point, because I think it's an important one. So, and it's important because for many surgeons, they're learning more and more about network meta-analysis because they're starting to see more and more published, very much like 10 years ago, we started seeing orthopedic meta-analysis happening. Then there was this explosion as software got better. Once software gets easy, people just start putting stuff into it, and then they start publishing, and that's a bigger problem, actually, quite frankly. But let's just say that we're at a point now where we're early. They see the rankings, and if someone says, oh my goodness, look, something ranked very high, what you would have done is saying, well, just because something ranked highly, just because something ranked highly, doesn't mean that it would actually, in your model, be the top. So you'd be looking at a number of variables. So something that ranked 1 on Sucre could in fact rank lower, much lower, and I presume that may have happened in some examples.
It absolutely happened in a number of cases, and in particular where we're looking at, 1 or 2 very small trials, and you get these huge treatment effects, but there was lots of loss to follow up, and you don't have confidence. Patients were blinded. So if you just look at the sort of effect estimate, it looks amazing. This is a fantastic therapy. But then once you incorporate risk of bias and how certain you are that that evidence is trustworthy, you lose confidence, and you say, well,
right.
Only very low certainty evidence. Maybe there's something here, but we are not going to catapult it to number 1 on the basis of 2 low quality trials of 30 patients with lots of problems.
And let me ask you one other point. I mean, the big issue is that there was so much skepticism in surgery, particularly, when meta-analysis came along, because there was, they're saying we don't, probably largely because it wasn't well understood, and there was a perception that meta-analysis of small studies, which was the majority of the orthopedic studies, wouldn't necessarily always be the most accurate truth to if that single large study had ever been conducted. And then we started seeing single large studies being conducted that were very different in I guess their treatment effects from small meta-analysis, which led even to more challenges around, we should be careful around small meta-analyses or meta-analysis of small trials. In network meta-analysis, are there examples, or are you aware of examples, and I suspect you are if they exist, of situations where networks have been done, they've postulated something, and then along comes a trial that did that exact comparison that wasn't available prior to that network. And has that comparison happened? So people have more faith that, okay, this tool is a useful tool.
Yeah, it has. I mean, it's a great question. And so people have looked at this. There was a seminal paper published in the British Medical Journal a few years back. I think the lead author's last name was Song, for people
Okay.
who want to try to find that. But they did look at the concordance of network meta-analyses with subsequent trials that head-to-head. And what they found, that it wasn't perfect.
Yeah, nothing ever is.
I think it was about 85%, about
Okay.
80% of the time the networks got it right, and that was borne out by the trials. But there was that sort of 12-15% of times where that wasn't the case. And you said before, when the software is available, people start putting these things out. They do, and you end up with a lot of very low quality reviews, which then make people very critical about the area in general. So, although we do say that systematic reviews, including network meta-analyses, are the sort of top of the evidence hierarchy, not if they're done poorly, not if they're based on a small handful of terrible studies. So increasingly, we're seeing that you have to appraise the quality of the systematic review.
Oh, yeah.
Not just say, oh, it's a systematic review. It must be giving me the sort of correct information.
Well, back in the day, I recall using the Oxman-Guyot tool for systematic reviews, and he had 7 questions, and the 7th question was an overall quality assessor. Is there something similar that you've been using, or you'd recommend, that could be used for those who are interested in understanding what would make some of the features of a good network meta-analysis? And I suspect those results, those features there, just because or if you're conducting them, we should be looking for those in those, when you did your own network, how are you appraising, and what methodological standards are you abiding by, so to speak? Is there guidance?
Well, there is a PRISMA statement that was written for network meta-analyses. And if you submit to any of the higher impact journals, they will demand that you adhere to that. So at least your reporting should be adequate. When it comes to assessing the quality of it, again, using this sort of PRISMA checklist is definitely a way to do it.
Okay.
There was a very sort of large overarching tool called AmStar, which is cumbersome.
It's very busy and long. Yeah.
Very busy and long. I know that there's another tool out there. I think the acronym is ROBUS. People are testing that one as well. There's a great course that's run out of McMaster every summer through the Clarity group on evidence-based medicine, and they have a very nice 1-page sheet to appraise the quality of a systematic review. I still tend to look at that. I mean, if I have to have sort of a cheat sheet to sort of appraise a review, it's a nice straightforward approach that makes sure that you look at the real critical components of it. But there is some movement to sort of find out, well, what is the best official tool for appraising the quality of systematic and meta-analysis?
And maybe I'll end on this last question before we close out here. Because I think we got into a methodology discussion, but it's really important because it's the methodology that also separates the work you've done from those who are just playing into standard programs where you can use network meta-analysis. What would be in your mind, from your experience of doing network meta-analysis, one of the critical factors that you have to get right in a network meta-analysis? Is it the quality of the primary studies that still reigns supreme in a network meta-analysis, or is there other factor beyond, that we think of beyond just a meta-analysis?
So definitely the quality of the primary literature is critical. I mean, no matter how sophisticated your approach is, you cannot turn a terrible study into useful information. So. Right. Yeah, you need to have good literature to work with. I think we have to try to get better and better and better at making sure that we have even better concordance between the results of a network meta-analysis and when that final head-to-head trial is done. So this paper I talked about by Song that was put out, I don't know, maybe about 7 or 8 years ago now.
Right.
It got a lot of attention because people said we want to get an even greater concordance. If people are going to be using these network meta-analyses and they're going to do it with confidence, it can't just be right 85% of the time. It's got to be like 99% of the time. So there's a lot of work that's being done now to sort of tighten up weaknesses, make sure that the results have a very low chance of sort of being misleading. We've talked a bit today about, moving away from the Sucre approach to one that actually considers the certainty of the evidence. As you have said, if you do not have a high quality study, you should not be making strong conclusions on the basis of that evidence. So I think, as with normal systematic reviews, we've got to make sure that we don't have greater confidence in the findings of a systematic review or network meta-analysis than is warranted. And you can't just do 100 sophisticated analyses and not be accountable to the sort of underlying quality of what you started with. So I think if we can do a better job of that and alert people to when our findings are not conclusive because there's lots of problems, people are going to have more confidence when we do come out with a strong recommendation from one of these reviews, because we say, in this case it is warranted, and we're very certain that this result is going to sort of stand the test of time.
Got it. So principally, be as conservative as you possibly can when interpreting results.
Absolutely. And I mean, there's lots of other things that we could talk about, but the other thing that I'll state that we sort of made efforts to do is we presented the effect estimates not only as relative effects, but also absolute effects. And unfortunately, we see too many cases where people say, "Oh, look, the relative effect looks so impressive with this with this number," but then when you look at it in absolute terms, because maybe the baseline risk is only 1% or 0.1%, even a relative reduction of 50% becomes not that impressive. So again, good methodology, reporting it in a way that's understandable, and always co-presenting absolute effect estimates with the relative ones as well.
Well, thank you so much. I mean, congratulations again on helping us think through chronic pain, the treatments that work, and more importantly, as you do this work, also advancing the science of how we do this work. Dr. Jason Busse, thank you so much, and appreciate your time.
Thanks for having me on.